and then I'll discussing the current biologic agent and therapeutic strategy in patients with Crohn's disease. And I talk about biologic positioning in patients with Crohn's disease, and then I will share some cases who treated with ustekinumab. IBD, most commonly categorized as Crohn's disease and ulcerative colitis, defined as chronic and inflammatory disorders of the GI tract characterized by abdominal pain, diarrhea, and hematochezia. Patients with IBD show alternating symptoms of disease relapse and remission, resulting in disease progression. The incidence of IBD in Korea have continued to increase over the past 3 years. This slide illustrates the 30-year change of IBD incidence in the Songpa, Gangdong area, Seoul, Korea. You can see that the age and sex-adjusted incidence have progressively increased over the study period. IBD is a Westernized disease, so the prevalence of IBD is very high in Europe and North America. In addition, the incidence and prevalence of IBD is rapidly increasing in newly industrialized country, increasing Korea. In developing country now, the prevalence is relatively low. However, shortly, developing country, including Vietnam, have a similar epidemiology in the prevalence and instance of IBD in the near future. The mechanism underlying the development and pathophysiology of IBD still need to be fully understood. However, complex interaction between the host and luminal factors are involved. Substantial progress in the pathogenesis of IBD has been achieved, which will lead to the development of new therapeutic target for IBD. You know that conventional treatment using corticosteroid or immunomodulators cannot modify this progression in patients with Crohn's disease. However, the use of anti-TNF agent induce mucosa healing, which reduce the risk of surgery and post-operative recurrence. So we believe that TNF pathway is considered an effective target for disease modification in patients with Crohn's disease. Over the last 20 years, more information regarding the effect of anti-TNF agents has been evident. However, there are some issues regarding a loss of response and sometimes primary non-response. In addition, adverse events such as infusion reaction and can develop in 20% of IBD patients. So there are great need to develop new agents involving other immune pathway in patients with IBD. Recently, a substantial progression in mucosal immunology of IBD has been achieved. The classic Th1 and Th17 pathway has been modified because of the identification of Th17 and Th19 cells. In addition, innate lymphoid cells has been identified as immune modulators, and molecular mechanism regarding the T-cell migration has been intensively studied, contributing to the development of a new therapeutic target in patients with IBD. Treatment vedolizumab is a monoclonal antibody to integrin alpha beta 7. So this can block T-cell migration to the intestine. Treatment with vedolizumab was effective in inducing and maintaining a remission in patients with UC and CD. In addition, no case of progressive multifocal leukoencephalopathy has been reported, so contributing FDA approval in 2014. Ustekinumab is a monoclonal antibody to P40 molecule, so this can block both IL-12 and IL-20 pathway. A phase 3 trial was performed to evaluate the effect of ustekinumab in patients with Crohn's disease, including some patients who exposed to TNF agent. The primary endpoint was the clinical response at week 6 of induction trial and clinical remission at week 44 in maintenance trial. As shown here, ustekinumab was effective in inducing remission regardless of TNF use and maintenance trial. This is the result of Unity long-term study. During the 252-week, a third of Crohn's disease patients can maintain clinical remission using ustekinumab with 8 to 12 weeks interval. So ustekinumab is an effective and safe agent in patients with Crohn's disease. Risankizumab is a monoclonal antibody to P19 molecule, so this can block IL-23 pathway selectively. A phase 3 trial was performed to evaluate the effect of risankizumab in patients with Crohn's disease, and as shown here, risankizumab was effective in inducing and maintaining remission regardless of the prior use of other biologic agent. Guselkumab is another P19 monoclonal antibody. Recently, the result of phase 2 trial was reported in gastroenterology, and as shown here, guselkumab was also effective in inducing remission in patients with Crohn's disease. So now we have infliximab and adalimumab, vedolizumab, and ustekinumab in patients with Crohn's disease. We will have much more agents because some agents are under phase 2 or phase 3 trial. You know that ozanimod is a S1P receptor modulator and was effective in inducing and maintaining remission in patients with ulcerative colitis. And now phase 3 trial for CD is still ongoing. In addition, we can use infliximab and adalimumab biosimilar. I think that we can use 10 more biologic or small molecular agent in the next 5 years. This is the data from IBD fact sheet by Cassid. This slide shows the trends of drug use in patients with Crohn's disease in Korea. As you can see, the use of immunomodulators slightly increased up to 60% of Crohn's disease patients, and the use of steroid slightly decreased. Surprisingly, the use of biologic agent has been rapidly increasing. So now a third of Crohn's disease patients use biologic agent to control their disease in Korea. Next, I'll talk about therapeutic strategy in patients with Crohn's disease. IBD is a progressive disease resulting in some complications such as stricture, fistula, and abscess. So the ultimate therapeutic goal is to reduce bowel damage and prevent complication and to improve quality of life. To achieve this goal, tight control and monitor of intestinal inflammation has been suggested. This slide shows the therapeutic strategy in patients with Crohn's disease. The first T2T approach for tight controlling and monitoring of intestinal inflammation has been suggested in the updated STRIDE 2 guidelines. In addition, early intervention, the resolution of intestinal inflammation early in the disease course using a top-down or accelerated step-up is very important to reduce bowel damage in patients with Crohn's disease. And finally, personalization using the prediction of disease progression is becoming one of the main strategy in patients with Crohn's disease. So these strategies can reduce intestinal damage, bowel-related complication, bowel surgery, and hospitalization, and to improve quality of life in patients with Crohn's disease. The concept of T2T is very essential because treatment based on symptomatic response alone is maybe insufficient to prevent future complication. The general approach of T2T involves beginning with a baseline assessment and establishing the treatment target, and then a regular assessment of this activity using a clinical, biochemical, and colonoscopy or imaging study allows clinicians to continue current treatment or optimize current treatment. This slide shows the treatment goal of IBD. You know that treatment goal in IBD is rapidly evolving. Mucosal healing is the best established treatment target in patients with Crohn's disease. Recently, deep remission, histological remission, and transmural healing has been suggested as the treatment target in patients with IBD. So an important question is the timing and frequency to monitor non-response to therapy or to confirm the resolution of intestinal inflammation in patients with Crohn's disease. This figure shows the STRIDE 2 guidelines. So symptomatic response has been proposed as short-term treatment target, and symptomatic remission and normalization of CRP and decrease in calprotectin has been suggested as intermediate target. And finally, endoscopic healing, normalized cure, and absence of disability has been proposed as long-term treatment targets. So we have to monitor these time-dependent treatment target are reached, and we have to consider treatment optimization if the targets are not reached in appropriate time. This slide shows the protocol of CALM study. A CALM study demonstrates that clinical and management based on symptom alone show the low rate of mucosal healing and compared with one based on composite strategy using clinical symptom and biochemical markers, including CRP and fecal calprotectin. The primary endpoint of CALM study was mucosal healing assessed by CDEIS. So these figures show that the tight control and monitoring group showed higher rate of mucosal healing compared with clinical management group. Next, I talk about early intervention using biologics. A top-down trial was performed to evaluate the effect of early combined immunosuppression using infliximab and azacitidine. 133 moderate to severe CD patients were enrolled in this study and divided into two groups, early combined immunosuppression and conventional treatment. The primary endpoint of this study was the steroid or biosurgery-free clinical remission at week 56 and week 52. As shown here, early combined immunosuppression was more effective than compared with conventional treatment group. CHAMP trial was a pivotal study to prove the effect of adalimumab in patients with Crohn's disease. In addition, post-hook analysis suggests that shorter duration, less than 2 years after diagnosis of Crohn's disease, was a significant predictor for long-term remission for 3 years. So these data suggest that early intervention using a biologic agent can modify this progression in patients with Crohn's disease. Next topic is personalization. You know that UC and CD are very heterogeneous condition. So some patients of CD have a benign condition, benign disease course, while approximately a third of CD shows very aggressive nature. So this early intervention or aggressive monitoring is helpful in this group, and conventional treatment or monitoring is appropriate in this group. A recent review suggests that this activity and this severity should be evaluated in patients with Crohn's disease at diagnosis. This activity is the burden of inflammation at any given point in time, and this severity is helpful in determining a prognosis and predicting a complication in patients with Crohn's disease. Using the severity and activity, we can evaluate the future risk of this progression. I'm sorry. Can I see my slide? Okay. So using according to the risk stratification and clinical features, and we can choose the best treatment option in patient with Crohn's disease. In Crohn's disease patient who has severe or extensive disease, or proximal disease, stricture, fistulizing disease, or perianal disease, we can choose a TNF inhibitor with or without immunomodulators. Okay. In moderate CD, when limited to coronary disease and with no high risk features, we can choose risankizumab and vedolizumab because of the better safety profiles. Next, I talk about biologics positioning in patients with Crohn's disease. This slide will show the Korean guideline for the biologics use in Crohn's disease. This guideline was published in Intestinal Research last year. Now we can use infliximab, adalimumab, vedolizumab, ustekinumab, and anti-TNF biosimilars in patients with moderate to severe CD who are refractory to or intolerant to conventional treatment, and also we can use them in maintenance treatment. However, we could not make a specific recommendation for biologic positioning because of the need of more clinical evidences. So personalized approach is very important when choosing biologics. So biologics positioning relies on numerous factors. So we usually consider efficacy, safety, extraintestinal manifestation, and convenience, and sometimes drug cost. This is the result of the CB study. The CB study was the first head-to-head trial comparing a biologic agent in patients with Crohn's disease. 386 biologic-naive Crohn's disease patients were enrolled in this study and then divided into two groups, adalimumab group and ustekinumab group. The primary endpoint was clinical remission at week 52. As shown in this table, there was no significant difference in clinical remission at week 52 between the two groups, and no other significant findings were observed, including clinical response and endoscopic remission. This table showed the result of adverse event between the two groups. There was no significant difference in adverse event between the two groups. However, ustekinumab showed a low discontinuation rate during the study compared with the adalimumab. So, based on this data, both adalimumab and ustekinumab have a great efficacy in biologic-naive CD patients. However, ustekinumab may have better safety profile compared with adalimumab. This is a result from a recent meta-analysis, including risankizumab. Infliximab combination treatment with infliximab and thiopurine showed the best efficacy in clinical remission in patients with Crohn's disease. However, ustekinumab have a similar efficacy compared with infliximab with or without immunomodulators. Active tuberculosis or latent infection should be evaluated in Korea because the prevalence of TB is relatively a little high in Korea. TNF inhibitor is associated with an increased risk of TB reactivation. However, vedolizumab and ustekinumab have lower risk of developing TB reactivation. In addition, we usually consider patient age, malignant disease, and viral hepatitis or some opportunistic infections such as CMV or CDPC infection. And so we believe that vedolizumab and ustekinumab have better safety profile compared with anti-TNF agent. Extraintestinal manifestations are common in patients with IBD. We can see some uveitis, psoriasis, and ankylosing spondylitis in patients with Crohn's disease because they share genetic, immunologic, and environmental risk factors. TNF pathway is very important in immune-related disease. So, TNF inhibitor showed efficacy in RA, IBD, psoriasis, and ankylosing spondylitis. In addition, P19 and P40 monoclonal antibody, including ustekinumab, showed efficacy in both psoriasis and IBD. So, we can choose ustekinumab in Crohn's disease patient with concurrent skin disease such as psoriasis. Convenience or preference is also important because Crohn's disease patients are relatively young and socially very active. Infliximab is an IV medication with 8-week intervals for maintenance treatment. So patients should stay in the hospital for 2 more hours. However, infliximab biosimilar can be administered subcutaneously with 2 weeks interval. Adalimumab also can also be administered subcutaneously with 2 weeks interval. Vedolizumab is an IV medication with 8 weeks interval. Ustekinumab is the most convenient agent after IV induction. Ustekinumab can be administered subcutaneously with 8 to 12 weeks interval. the cost. This table shows the frequency of biologics use between Western Europe and Eastern Europe. As you can see here, the frequency of biologics use is more frequent in Western Europe compared with Eastern Europe. And biologics-related cost is rapidly increasing after the diagnosis of Crohn's disease. So cost is very important when choosing a biologic agent. Biosimilars are a biological product that is highly similar to a reference product. There was no clinically meaningful difference in terms of safety, purity, and potency. Switching from the originator to a biosimilar in patients with IBD is acceptable following an appropriate discussion between patient, nurse, and patient. In Europe, average biosimilar price have been 30% lower than the reference product. This is the last slide in summary and conclusion. Crohn's disease is a progressive disease which lead to some complications such as stricture, fistula, and abscess. Early intervention, personalization, and T2T strategy with tight monitoring are very important to improving long-term outcomes in patients with Crohn's disease. Physicians should consider the patient preference, cost, adherence, safety, and speed of response to the drug when choosing a biologic agent. Next, I show some cases. We have 58 Crohn's patient who treated using ustekinumab. Approximately 70% to 80% patients show clinical response or clinical remission after using ustekinumab in the real world practice. This is the first case. First case was a 50-year-old female. She had pulmonary fibrosis. She was diagnosed as Crohn's disease in 1993 and then treated with conventional agents including steroid. She got surgery, first surgery in 2002 because of pain abscess. Influenza was the first biologic agent and started in 2012 to control intestinal and biliary inflammation. She got second surgery due to perianal fistula in 2015. Second biologics vedolizumab was used to control inflammation in 2019, and then vedolizumab dose escalation was in 2020. However, a signal improvement was not achieved after the high dose of vedolizumab. So, ustekinumab induction was done in 2020. After the induction of ustekinumab, symptomatic improvement was achieved. This is the photos of colonoscopy before and after the use of ustekinumab. As shown here, multiple longitudinal ulcers and pseudopolyps were found before the use of ustekinumab. You can see that nearly mucosal healing was achieved after the use of ustekinumab. This is the second case. Second case was a 50-year-old male. He had no past medical history. He was diagnosed as Crohn's disease in 2018 and treated with conventional treatment, including steroid. First biologic agent was also infliximab in 2018, and dose escalation was done in 2019. And mucosal healing was achieved in 2020. However, a loss of response was developed in 2021. So, induction treatment using ustekinumab was done in 2021. After the treatment, symptomatic improvement was achieved, and mucosal healing was also achieved after the use of ustekinumab. This is the last case. The last case was 36-year-old female. She had no specific past medical history. She was diagnosed as Crohn's disease in 2013, and she used conventional treatment. In 2018, symptom aggravation was observed. So conventional treatment was done. However, there was no response after the conventional treatment. So induction treatment using ustekinumab was done in 2019, and symptom improvement was achieved. And then we can see a mucosal healing after the use of ustekinumab in this patient. Okay, thank you for your listening. I hope to see you in AOCC in 2023 in Busan. Thank you.
Thank you.